Hey Dan. So I'm going to be doing my audio presentation on pericarditis. Uh, Pericarditis by me, Born Roden. I forgot. Really annoying. First I'm going to talk about the risk factor. So I kind of broke this into two sections. The first section being cardiac stemming, and the second section being just common illnesses. So for the cardiac stemming, just because pericarditis is an infection of the pericardial sac, a lot of heart problems tend to lead to this. So previous MI, I did some independent research, and I found that 10 to 15% of MIs lead to pericarditis. And then cardiac trauma, this can set the same beginning steps of the pathophysiology for pericarditis. So if your heart becomes irritated from trauma, it can have the inflammatory response, which could lead to fluid shifting and get the whole ball rolling on that. And from common illnesses, there's kind of four big things I picked up. Autoimmune diseases, just generally being sick, kidney failure, medications. There's two I found here that are really important, one for seizures, one for dysrhythmias. Another big one were surgeries to the mouth. These all lead just because your body, it's kind of same thing. Beginning steps are still there. Your set point for your temperature is higher. There's a white blood cell activity. There's vasodilation. If it just happens to get a little infected in the heart too, same thing as cardiac stemming, the ball is rolling on pericarditis right there. And before I got into pericarditis and the whole pathophysiology, I kind of just wanted to break down some categories for this, and then there's four ways you're able to get a correct answer if you have this going on in your body or in your heart. So radiographic imaging, echocardiograms, electrocardiograms, and laboratory testing were the four main techniques I found. So the radiographic imaging, this can be chest x-rays, this can be CT scans, this could be an MRI. This just to see the general, you have a gross picture of the mass of the heart, and you can see if there's any inflammation of the pericardial sac. For echocardiograms, it's the same thing, but this is through sound. So you can see the size and the motion of the heart through the echocardiogram. The electrocardiogram is to see electrical activity through the heart. So if there's inflation or inflammation in the pericardial sac, this will reduce the total surface area of the heart and the ventricles that are having the electrical output properly delivered. So you'll see it, the electrical output actually stopping sooner when you have the pericardial effusion and tamponade pericarditis thing going on. And laboratory testing, this is to see if your body has the blood work that's similar and suggestive of being infectious of an illness. And then the categories I wanted to get into: acute, subacute, and chronic. The big one that we're going to focus on in this project is chronic. So this is generally when you've had pericarditis or it's reoccurring for more than around 6 months. Subacute is a couple of weeks to up to that 6-month point, and then acute is kind of just a rapid short-term pericarditis. And even people in our class have or had the acute, but the chronic is kind of where there's some more life threats involved. So what is pericarditis? So this is an infection to the pericardium or the pericardial sac, and this comes when white blood cells cause inflammation to the pericardial sac. And as we know, white blood cells will result in vasodilation. Vasodilation results in fluid shifting. And when this fluid shifts into the pericardium, this is where the problems begin to occur. Under 100, 200 milliliters, this is still pericarditis. And this tends to lower the contractility of your ventricles, which will reduce your cardiac output. And also with fluid shifting, you're going to see some fibrosis and some tissue damage to the exterior portions of the ventricles, which will result in stiffening to the pericardium, which is the same thing. It reduces contractility as you don't have the strength to contract your heart properly and pump out the blood as you normally would. And then I kind of went into here to pericardial effusion and pericardial tamponade. So effusion, this is where that 100, 200 milliliter target range I mentioned earlier gets met, and that much excess fluid shifts into the pericardial sac, and this really compresses the ventricles even more, and contractility is impaired. At this point, you can see the QRS alternance when you see a big QRS, small QRS, big QRS, small QRS, and this is suggestive, and it shows what's going on in the heart. And I don't want to say the heart's bouncing around, but the excess fluid causes the heart not to be stable in the pericardial sac. And you'll see the heart kind of shift a little bit with each beat. And when you're doing a 12 lead or a 2 lead, you can kind of see the QRS alternance because the way the cameras are positioned, it would be further or closer away from the camera because the heart's like essentially moving inside the pericardial sac. And then tamponade is when this progresses and becomes essentially a life threat. And the visceral pericardium is going to be really stiff here, which further reduces the contractility. And this also reduces filling at this point as contractions and relaxations are going to be impaired. And when the relaxation of the ventricles is impaired, the preload inside of the heart or inside of the ventricles also impaired, which leads to these life threats, especially in the chronic setting, as you'll be chronically deprived of a proper cardiac output, which will make you chronically low on MbO2, which leads to a lot of pathophysiology that we've touched upon in this course already. Before I got into the life threats, I just want to talk about some symptoms you'll find through pericarditis, pericardial infusion, and pericardial tamponade. The first thing I want to touch upon, even though it's at the bottom of this list here, is Beck's triad. So this can be the low blood pressure, the narrow pulse points, and there's kind of 4 things. The muffled heart sounds in the JVD. This just stems from your heart not having enough strength to properly move all the blood inside of the body and not have it be able to properly flow back into the heart as relaxation is impaired, preload's impaired. So there's going to be some blood stagnation inside of the veins, and this can be seen in your JVD. So you'll see an enlarged JVD there. And then I'm going to touch upon edema later, so I don't really want to talk about too much right now. Muffled heart sounds as the pericardial sac's going over the heart. You're not going to be able to hear the heart as well as there's a bunch of fluid in the way. And then I already talked about JVD. And the low blood pressure is the contractility of the heart's impaired. It doesn't have the strength to properly withhold and withstand in the normal blood pressure that the heart wants. So the pain you'll feel with pericardial or pericarditis, it can radiate to the shoulder, neck, or back, but it usually presents in the middle or the left portion of your chest. And this pain or the shortness of breath that you feel associated with this pain increases when you're lying prone and supine. This is because the fluid inside of your pericardial sac is gravity dependent. So when you lay down, your heart's going to have a larger amount of surface area that is being impaired by the excess fluid, which will further cause these pains of your pericarditis to get worse. You become febrile. So as your hypothalamus detects kind of the infections going on, it's going to have a higher set point of your internal body temperature to fight off the infection. But as your infection and your set point temperature are raising, you're going to find that you're febrile as well as your temperature is higher. Muscle weakness, heart palpitations, shortness of breath. This just becomes from the lower SpO2, or not the lower SpO2. As your heart's not pumping as much blood, your oxygen in your tissue is not as supplied as often. Therefore, your tissue and your body is going to feel slightly hypoxic when it gets to your brain, just because the stream of oxygen is lower than the heart and the body is capable for it to handle. This isn't the same thing as when like athletes have a low heart rate or low blood pressure, because their body is able to kind of contract and get all of the oxygen they need. And they kind of have, I don't want to say understanding, but the body understands like how much it needs. But in this case, it's not the body's purposefully reducing the heart rate. It's the body is contractility is being impaired by an infection. Thus, you feel hypoxic because you literally are becoming hypoxic. And then edema to the legs or abdomen, same thing as the JVD. Your heart doesn't have, like the blood pressure doesn't have the strength to bring up all of the blood the same way. So in places that are more common for pitting, being with the legs and the stomach's ascites, but the legs is really big because it's the lowest gravity dependent peripheral and extremity to the body. So the blood will stagnate there a bit more, which will cause, when it gets there, same thing, the vasodilation, the fluid shifting, and you kind of see the skin become a little bit inflamed, which you'll see in this edema. The life threats associated with this, I broke this down into 2 ones. They're kind of similar, but they come from different ways. So this is remodeling of the heart leading to cardiogenic shock. So this is why it's important to remember that I'm talking about chronic pericarditis here, because when you have a chronically low MVO2 from pericarditis, your heart's going to remodel and hypertrophy to try to overcome this as a compensatory method. But as your heart is being infected and it has an illness here, it won't build the strength properly to adapt for the hypertrophy. So you're going to have more fibrosis almost already going on, which will lower contractility even more. And as hypertrophy of the muscle is enlarged, the vessel and the amount of area that can actually withhold blood is reduced. Therefore, the preload is going to be produced. So you're going to have an even lower preload because now your relaxation is impaired from the pericarditis, and now the hypertrophy from the body is causing the preload and the vessels to get smaller. And if this happens for too long, the afterload is going to remain essentially the same, but your preload and your body's ability to contract and get so impaired that it will be unable to overcome the afterload. And this is when it becomes cardiogenic shock, when your body and your ventricles are no longer able to overcome the afterload. Right away, it won't be irreversible shock. It'll be kind of more sustainable. So you're going to see an increase in heart rate to kind of manually cause an increase of blood pressure inside the ventricles. So you're going to see an increased electrical heart rate, but the physical palpable heart rate is going to be pretty slow because it needs multiple beats to build up the pressure. But moving over into obstructive shock, this is when it is in the afterload, which is impairing your heart's ability to conduct. It is damage to the ventricles, and this will come from the tamponade physically pressing on the ventricles and not allowing them to contract correctly, and therefore the heart is going to have the same problem as it won't be pumping, but this is from the ventricles being impaired, not the afterload being too high. That's all. Thanks for listening.